Okay, well, welcome guys. My name is Rod Quilitz. I'm a clinical pharmacist in infectious disease and oncology here at Moffitt Cancer Center. And our topic today is invasive fungal infections, which unfortunately I've seen more than a few of them here. This is my institution of practice, Moffitt Cancer Center Research Institute. And here I encounter the enemy. Basically what I'm going to do today is talk about the major risk factors which predispose immunocompromised patients to invasive fungal infections, briefly review some of the most commonly encountered and deadly fungal pathogens in clinical practice, and compare and contrast the available antifungal agents that we have, focusing on spectrum of activity, efficacy data, toxicity, drug interactions, and therapeutic drug monitoring issues. So in terms of the history of fungi, they've been in existence over 300 million years, so considerably longer than we have, over 2 million species. They're free-living. Most of them are of limited pathogenicity, and less than 200 species are associated with human disease. Far more of them are useful. They can also be incredibly useful to us. They can be edible, yeast for bread, or as a Florida Gator fan, for brewing beer. And we wouldn't have penicillin if it wasn't for penicillium. But in the last few decades of the 20th century and into the 21st century now, we see an increase in new and rare mycoses with substantial morbidity, mortality, as well as some potential for drug-resistant strains. And we're seeing this as we see more and more immunocompromised patients, victims of our own success in keeping these patients alive. Okay, so in order to develop an invasive fungal infection, you have to be exposed to the fungus. The host acquires the pathogen, which competes with the patient's normal microbiological flora. Disruption of skin and mucous membrane barriers will facilitate this, for example, and then you have to have sufficient growth in order to overcome host defenses. In terms of the impaired host defenses, we're talking about immunodeficiency states here, right? So from a drug-induced standpoint, so you have chemotherapy, corticosteroids, other immunosuppressive agents which are used to prevent or treat graft rejection or graft-versus-host disease in our stem cell transplant patients. Whole body radiation is immunosuppressing as well. Patients with congenital conditions such as CGD, SCIDs, MPD, or patients with acquired impairments in their immunodeficiency state, such of course as HIV/AIDS. Patients who have cytomegalovirus have also been shown to be immunodeficient in addition to the deficiency that led to the CMV infection, and the very old and the very young. In terms of the relative risk factors for the development of invasive fungal infections in general, the two major factors that we think about are the severity and duration of neutropenia. So the risk grows substantially the longer the patients are neutropenic, and most notable in those patients who are neutropenic for more than 2 weeks. Also, patients who are chronically lymphopenic with CD4 counts less than 100 are at increased risk as well. So, this is a little cartoon to just kind of show the fungal cell structure. This, of course, is an example of a yeast, but in general, we have these different sites that our antifungal drugs can attack, right? In terms of the membrane function, we have the polyenes, most notably amphotericin, but also nystatin falls in this category. In terms of cell wall synthesis, we have our echinocandins. Ergosterol synthesis is inhibited by our azole antifungals, and nucleic acid synthesis is inhibited by our pyrimidine analog, which is 5-fluorocytosine, flucytosine. Okay, so at a very basic level, yeasts are unicellular. They're oval or round in shape. They form these fuzzy matted growths called mycelia. They reproduce by budding, whereas the molds consist of these thread-like filaments, also known as hyphae, which can be divided by transverse walls in the septated hyphae, or if there are no such divisions, they're called aseptate, and those are our zygomycoses, which we'll discuss a little later. Also, the molds have Candida, which are non-motile spores, which are responsible for asexual reproduction. Okay, so there are a wide variety of clinical important fungal pathogens, and in terms of our yeasts, our molds, and our dimorphic fungi, because of time constraints with this lecture. I'm going to focus predominantly on some of the more commonly encountered in the immunocompromised patients. So we're going to talk about Candida, Cryptococcus, Aspergillosis, Fusarium, and the Zygomycosis, and I'll touch on some of the others as time allows. Okay, Candida, right? It's part of our normal flora, the skin, the female genital tract, and the GI tract. Neutrophils are a critical part of the host defense against Candida. So it's a major problem with neutropenic patients. We see mucocutaneous infections, oropharyngeal, esophageal, vaginal. But unfortunately, we also see systemic infections as well. Candidemia, Candiduria, disseminated candidiasis. And disseminated candidiasis is a critical issue for us, right? So we know that fungemia, predominantly candidemia, accounts for approximately 19% of positive bloodstream infections in severely septic ICU patients. So it's definitely something to consider, especially for those ICU patients who are neutropenic, or they have heme malignancy, poorly controlled diabetes, other immunodeficiency states, high-dose corticosteroids, immunosuppressants, antineoplastics, if they have central venous catheters, receiving hemodialysis, TPN, prolonged broad-spectrum antibiotic use, or recent extensive GI tract surgery. And only in various series, only about 25 to 45% of neutropenic patients who die and are found on autopsy to have disseminated candidiasis actually had positive cultures prior to death. So it can be a silent killer too. So disseminated candidiasis can go just about anywhere, right? It lives up to the word disseminated. So in the abdomen, we can see it as a component of an abscess, as peritonitis. We can see it in bone with homogeneous spread to the spine, sternum, or femur, for example. Patients can have central venous catheter infections with Candida quite commonly. You can also have fungal endocarditis or a superinfection of bacterial endocarditis with Candida. It's not commonly seen in the CNS, but you can see it status post neurosurgery. It's also been reported in IV drug abusers, alcoholics, and premature infants. It can invade the joints. You can have aseptic arthritis with Candida. This usually occurs status post trauma or in patients with underlying joint disease, patients with prostheses, and this is usually a monoarthritis. In terms of the lungs, we basically say there's no such thing as Candida pneumonia. The only exception is a bilateral nodular pneumonia, which can be caused by a homogeneous spread where basically this Candida is going everywhere in the body, and the lungs are not an exception. I'll show you a picture of that. And in terms of urinary tract infections with Candida, that's quite rare, but we can occasionally see it in diabetics, patients with hydronephrosis, chronic indwelling catheters, or renal stones. Okay, so these photos here are basically to show some of the sites of disseminated candidiasis. And to your left, you can see what it's like the classic, what used to be called hepatic splenic candidiasis, right? So you can see this. See those little arrows are pointing out the Swiss cheese effect, right? These holes are caused by neutrophils attacking the yeast in the liver. So we actually don't see this picture in a neutropenic patient, but we can see it shortly after neutrophil recovery. And in the upper right-hand corner, you can see those very round bullet-like, essentially Candida septic emboli in the lungs from a disseminated candidiasis. And also, it's important to note ocular involvement. These patients benefit from an ophthalmological consult as well. So why do we care? Part of the reason that we care is that the attributable mortality in highly immunocompromised patients, such as stem cell transplant patients and solid organ transplant patients, is approximately 24%, so about 1 in 4. Okay, so I think it's very important to understand the antifungal spectrum of our agents against Candida because it's often misunderstood by our colleagues. All right, so when think about Candida albicans, Candida kefir, Candida dublinensis, and Candida tropicalis as being pretty much, usually they're the pan-sensitive Candidas. Now when we get into some of our trickier ones, you have Candida glabrata, Candida glabrata likes to create efflux pumps that can be efficient at effluxing out azoles. So roughly, it varies from area to area, but roughly a third of your Candida glabrata at most may be sensitive to fluconazole. Another third may be sensitive dose dependent, meaning you have to hike up your dose of fluconazole to overpower those efflux pumps. Those patients often get 800 milligrams a day or more of fluconazole, or the efflux pumps are just so efficient that that fluconazole is completely inactive against the Candida glabrata. It's important to note that other azoles, there is some cross sensitivity here in terms of these efflux pumps. So it's not unheard of for voriconazole or posaconazole or itraconazole to have reduced sensitivity with Candida glabrata as well if fluconazole does. It may be an option, but you definitely need susceptibility data to make that call. So echinocandins or amphotericin is going to be your treatments of choice for Candida glabrata infections, certainly before you have susceptibility data. Candida krusei is intrinsically resistant to fluconazole. It cannot bind in order to inhibit ergosterol synthesis. On the other hand, voriconazole, posaconazole maintain their activity in echinocandins and amphotericin as well. Okay. Candida parapsilosis, Candida garramundi tend to be fairly pan-sensitive, but they tend to have higher MICs against our echinocandins. So if you see a breakthrough on an echinocandin, it's not uncommonly one of those two, and parapsilosis is more common of the two. And we also want to note that Candida lusitaniae is intrinsically resistant to Amphotericin B. So a rare organism, but an important one. Okay, moving on to another yeast. Moving on to Cryptococcus. So Cryptococcus is a ubiquitous encapsulated yeast, and it's commonly found in soil and pigeon droppings, and it's acquired via inhalation. And the most common sites of infection with Cryptococcus are the lungs, right? The patients can have cough, rales, shortness of breath, but also the CNS. So you can have non-specific meningeal symptoms, headache, fever, nausea, vomiting, and altered mental status. I'll mention as well that you can have a Cryptococcus fungemia in immunocompromised patients. So we think about Cryptococcus neoformans, because that's been our longtime enemy, as a source of non-contagious systemic infection in these immunocompromised patients, including in end-stage AIDS patients, but we can also see them in our stem cell transplant patients as well, especially our allogeneic stem cell transplant patients as well. But I also want to mention the species Cryptococcus gattii, which arose in the Pacific Northwest and has been moving its way through the country, and yes, it's made it to Florida. And that has caused cryptococcal infections in relatively immunocompetent patients as well. In terms of the treatment of Cryptococcus, I highly recommend IDSA's guidelines, actually for a variety of these antifungal drugs. So I stole some of these slides directly from there. Basically, what I'm trying to tell you from this table is that for patients who have mild to moderate pulmonary Cryptococcus, you could actually treat these patients completely with fluconazole, but those patients with severe pulmonary cryptococcosis, you're going to treat them aggressively, just as you would a patient with CNS disease on the next slide. Patients where you actually are able to rule out CNS disease without fungemia, single site of infection, and no immunosuppressive risk factors could also be treated with fluconazole. Whereas our cryptococcal meningoencephalitis needs to be treated with a combination of a Amphotericin B product, ideally in combination with flucytosine to more rapidly sterilize the CSF, with the step-down therapy generally being fluconazole. There are a variety of other options that are perhaps not as effective or as well studied for patients where this plan is impossible, and I highly recommend the IDSA guidelines for perusing. Same concept here. Okay, so I'm going to move on and talk about Aspergillosis. Right, Aspergillus is, now we're moved on to the molds. Aspergillus is a ubiquitous mold found in soil, water, and plants. And some of the more common species that we see are Fumigatus, Flavus, Niger, and Terrius. This can cause superficial infections, like cutaneous infections. It can also be a cause of allergic pulmonary symptoms in some patients. But what we really fear are like our aspergillomas, our fungus balls in the lungs and the brain, and invasive disseminated aspergillosis. Okay, so the purpose of this slide is kind of twofold. One is to talk about the diagnosis, which is very challenging with Aspergillus. So rarely are our cultures positive for Aspergillus, except occasionally our sputum or BAL cultures will grow it, and then we have to consider the clinical picture, whether this represents respiratory colonization or in fact the whole picture is consistent with an invasive pulmonary aspergillosis. Even with biopsy and bronchoscopy, historically we've only gotten a diagnosis of aspergillosis about 40% of the time. Now this is about to change, I think, because now we're starting to get some new diagnostic assays which will be helpful here. So we already have the galactomannan assay. Galactomannan is a cell wall polysaccharide, and we can detect it in the serum, although there are a number of false positives, and we get false positives for patients who are on Zosyn as well because of contamination with penicillium, or products of penicillium. So this can be useful for early detection of aspergillosis as a screening tool. It's FDA approved for the serum, and I was just informed last night that it's been FDA approved for use with bronchoscopy, which actually is very exciting, which can help us pick up perhaps quite a few more of these cases and get a more definitive diagnosis. So that's okay. But the reality is we often wind up looking at a CAT scan and trying to determine whether this patient likely has IPA. One of the major risk factors, as you can see in the chart to the right there, is that, and this is very old data, going back to like 1984, but it shows the concept that without prophylaxis, if you're neutropenic long enough, you have upwards of a 75% chance of developing invasive pulmonary aspergillosis. Okay, so what do we see on the CAT scans? Well, on the top is a nice example of the halo sign, right? So you see these nodules with a ground glass attenuation surrounding them. And this is due to alveolar hemorrhage. And this is an early sign of aspergillosis and is progressively less frequent with time if you repeat these CAT scans. So you don't have to have the halo sign in order to have invasive pulmonary aspergillosis. And on the bottom is a really pretty example of the air crescent sign, right? This is pretty much considered pathognomonic for Aspergillus. It indicates a necrotic area. It's caused by the attack of neutrophils, and it's a later sign, and it's not seen during neutropenia. This is an example of aspergilloma in the brain, unfortunately. You can see all the hemorrhage that's occurring. This is a cutaneous aspergillosis associated with a traumatic inoculation in an immunocompromised patient. Okay, so we care about aspergillosis because it's the most common of the invasive molds, and it's associated with a substantial, with a very high mortality rate, and essentially the more immunocompromised the patient, and the less we can do about the patient's immunocompromised state, the greater the mortality risk. In terms of the antifungal spectrum against Aspergillus, obviously we lose fluconazole here. It has no activity against molds. Itraconazole has some activity. We no longer have a IV dosage form, and the oral is not reliably absorbed. Voriconazole and Posaconazole, the most in vitro active. The kind of cannons are active but static against Aspergillus, and of course Amphotericin has been our treatment of choice for Aspergillus for about almost 50 years before Voriconazole came out. Aspergillus terreus, however, is a species that is intrinsically resistant to amphotericin. It used to be one of the biggest killers that we had. Also be aware of disseminated Aspergillosis infections, which have been reported in allo stem cell transplant patients despite voriconazole or caspofungin prophylaxis. And the treatment of choice for Ustis appears to be Amphotericin B. And certainly lipid formulations would generally be preferred in these patients. In terms of Voriconazole really was a breakthrough drug in the treatment of Aspergillosis, and we actually have a randomized clinical trial comparing frontline Voriconazole to conventional Amphotericin B. And you had 277 patients with proven or probable IA randomized to either get Voriconazole or conventional Amphotericin B. And the Voriconazole patients were treated for a median duration of 77 days. Unfortunately, the Amphotericin B patients were treated for a median duration of 10 days because 80% of them had to be switched to other licensed antifungal therapy due to nephrotoxicity predominantly. So the excess at 12 weeks favored Voriconazole. The survival at 12 weeks favored Voriconazole, 71% versus 58%, which was statistically significantly higher for Voriconazole, therefore making Voriconazole the first-line treatment of invasive aspergillosis. So the question has come up whether we should be giving combination therapy for invasive aspergillosis, and this is the data that this is the only randomized clinical trial data we have so far, and it has not yet been published. This was 277 allo stem cell transplant patients and patients with heme malignancies with proven or probable IA who received Voriconazole plus or minus indicylofungin, and their combination therapy was administered for 2 to 4 weeks, and before they went back to single agent Voriconazole. At the week 6 mortality was 28% versus 19%, which was not quite statistically significant. The authors did a post hoc analysis of 218 of those 277 patients who had a positive galactomannan either from their serum or the BAL, and in that subset, which was not predetermined, 27% versus 16% survival, and so therefore that met the criteria for statistical significance. Warning, it's a post hoc analysis, so to be taken with a significant grain of salt. And of course, we await publication of this in a peer-reviewed journal. Okay, Fusarium. Okay, this banana-appearing mold here is found in soil, plants, and water again. It's a cause of superficial infections, keratitis, onychomycoses. It can be locally invasive or cause disseminated infections in severely immunocompromised patients. Most common species include Fusarium solani, 50%, Oxysporum, 20%, Reticuloides, 10%, and Maniliforme, 10%. Species will be important later. So Fusarium is like our number one cause of toe lesions, which are near the nail or interdigital in neutropenic patients, and these are like these can be violaceous nodules. They can be painful. We need to biopsy them or nail removal for culture. We also, for the derm disseminated lesions, we need a deep biopsy. And also of interest, when you have a patient with disseminated fusariosis, it's worth getting a blood culture because you can have or when you suspect it, you can get a blood culture because the blood culture may be positive for Fusarium. It's the only mold it's the most common mold to do that. Okay, and this is an example of why we get so excited about toe issues, swollen toes, and so forth. This was an example of a Fusarium infection got in through the toe at like a traumatic inoculation. The neutropenic patient banged itself, and now it's starting to spread upwards, right? And this can be the situation where you can wind up losing the toe, losing the foot, etc. And the example of a patient with multiple nodules from disseminated Fusarium. So how do we treat it? Well, in an ideal world, localized infections are debrided. Use Amphotericin B at high dose, or more commonly, in order to get tolerance to lipid formulations. Voriconazole definitely has a role, but it's important to note that Fusarium solani or Reticuloides are usually azole resistant. Unfortunately, we rarely know the speciation or the susceptibilities when we have a Fusarium infection. And so combination therapy often winds up being used for disseminated disease in highly immunocompromised patients. So often we'll wind up using like a lipid formulation of Amphotericin B plus Voriconazole. And there is some limited data on the benefit of adjunctive GM-CSF and or interferon gamma for refractory cases. Okay, so talking about some of our other, some of our emerging molds. So Fusarium, as we mentioned, Voriconazole, Posaconazole, and Ambisome have the best in vitro activity. Cedosporum apospermum, also known as Pseudoschiria boydii, has the extended spectrum azoles, Voriconazole, Posaconazole have the most activity far and away. So we consider that to be the treatment of choice for Cedosporium, particularly Voriconazole. Unfortunately, we had a recent case of disseminated Cedosporium proliferans, and it's pretty much plus minus for the extended spectrum azoles. For amphotericin, there's some data suggesting that adding in a kind of Candida may help. There's like one case report where terbinafine was thrown in the mix. The key is recover your neutrophils in order to have a chance of surviving this horrible mold infection. And also, we won't have time to go into depth about it, but the Yeasts Molds such as Alternaria and Bipolaris, the extended spectrum azoles are our most active agents there as well. Okay, last mold I'm going to talk about are the Zygomycoses, right? These are the molds from the order Mucorales, like Absidia, Cunninghamella, Mucor, and Rhizopus. And they can cause infections in the gastrointestinal tract, cerebral, maxillofacial, pulmonary infections, particularly in our prolonged neutropenic patients with heme malignancies, and also seen in very poorly managed diabetics. The mortality rate is about 44% in diabetics, about 66% in patients with malignancy. And this is an example here of a Cunninghamella pneumonia. And this actually is this is a nice example of a patient who actually did respond to therapy. The one on the right, the really nasty wedge-shaped nodule, which is kind of classic for Zygomycoses, showing about a month later, we've made this much improvement. And so you just have to keep following serial CT scans to keep up the aggressive therapy. And neutrophils help a lot. Okay, this is a concept of the reverse halo sign, kind of almost like if you look at that nodule on the left-hand side, you can see that in the interior, you almost have this, the ground glass is on the inside, almost like a donut kind of appearance. Right, this is seen in about 19% of patients with pulmonary zygomycoses, less than 1% of invasive pulmonary aspergillosis, and not seen with fusariosis, which tends to be more disseminated, multiple small nodules in Fusarium. This represents infarcted lung with greater hemorrhage in the peripheral solid ring than in the center ground glass region. So that can give you a hint that you might be dealing with zygomycoses. So the most active agents we have are Amphotericin B, and we use generally high doses of the lipid formulations, and Posaconazole. Voriconazole is not active against zygomycoses. There are some murine studies suggesting benefit of combination therapy with Amphotericin B with a kind of Candida. So that's something that we've been known to do, especially when patients are unable to take oral Posaconazole or unlikely to absorb it. There was an interesting concept called chelation therapy, right? So we know that defuroxamine or desferol, which is used for iron overload, actually can increase the risk of zygomycotic infections by increasing free iron. But XJade or deferosox has in vitro activity against mucor, and it actually decreases free iron because it so tightly binds to the iron. And so a randomized double-blind placebo-controlled trial was performed. Unfortunately, due to the rarity of zygomycoses, we only have 20 patients in it. Right? They received Ambisome plus or minus XJade. And unfortunately, they had a higher mortality in the XJade group. So at 30 days, 45 versus 11%. 90 days, 82% versus 22%. So unfortunately, that did not look promising. There was a very small number of patients. They were not evenly distributed in terms of cancer patients versus diabetics. But nonetheless, it's not something that we're likely to see pursued. All right, so let's stop talking about bugs and start talking about drugs. I'm going to start talking about the antifungal agents that we have to fight these bad players. And this slide is my wish list, which is completely fantasy, unfortunately. An antifungal drug with broad spectrum activity, minimum manageable toxicity, minimum manageable drug interactions, with well absorbed oral and intravenous dosage forms. And since I'm writing a letter to Santa Claus, why not ask for low cost too, right? World doesn't work that way, unfortunately. Okay, well, starting with conventional Amphotericin B, or Amphotericin B deoxycholate. This is a polyene antifungal which has been available as an IV formulation since the 1950s. It's fungicidal. It has a broad spectrum of activity against most of our yeasts and molds, and conventional Ampho B can be dosed as low as 0.3 milligrams per kilogram per day for like a Candida albicans in the urine, up to like 1.5 mg per kg per day for mold. And back in the day, we used to dose to like cumulative doses of Amphotericin B. Amphotericin B actually works by binding to ergosterol in the cell membrane and creating a pore, and you actually get influx of extracellular fluid, resulting in swelling and bursting of these cells, and that's how it kills. Amphotericin B is often called Ampho-terrible because of the toxicity profile. Thrombophlebitis can be a problem, so we have to use central lines or use a very dilute solution if patients don't have central access. What patients tend to hate are the infusion reactions, right? The shake and bake syndrome, fevers, chills, rigors, less commonly acute dyspnea, hypoxia, nausea, vomiting, headache, arthralgias, myalgias. These patients can be pre-medicated with Tylenol, Benadryl, hydrocortisone, may reduce incidence and severity of these reactions. It's kind of very much a trial and error process with patients who don't tolerate the drug well. And these rigors can respond to merperidine, morphine, or hydromorphone dilaudid, which is what we use commonly. Now, the other concern, of course, is nephrotoxicity, right? With a dose and duration related risk for nephrotoxicity. In terms of a fall in GFR, rise in serum creatinine, also increased urinary loss of potassium, bicarbonate, magnesium is not to be underestimated and needs to be monitored very closely. And you have reduced production of erythropoietin over time. This can lead to a chronic anemia while you're on amphotericin. Okay. Also, there is some benefit of saline loading, perhaps particularly during the first 2 weeks with Amphotericin B to reduce the nephrotoxicity. Okay, but the lipid formulations were developed in order to make this a more tolerable and deliverable drug. So trying to increase drug delivery, decrease toxicity, and allow us to administer a full course of therapy. And currently we have 3 lipid formulations of Amphotericin B: liposomal, which is Ambisome; Amphotericin B lipid complex, which is Abelset; and Amphotericin B colloidal dispersion, which is Amphotec. So this is a pictorial representation of the structures. It greatly exaggerates the size of Ambisome, which is a true liposome, whereas Abelset is the largest, has this long ribbon-like superstructure, and Amphotericin B colloidal dispersion has more of a disc-like superstructure. And structure actually is relevant because the large ABLC has a lower serum concentrations, it's a short half-life, large volume of distribution, which is the exact opposite of Ambisome. In terms of the toxicity differences, we have so Amphotec ABCD. The reason it's really not one of my favorite drugs is that it actually has a higher incidence of infusion-related reactions than conventional Amphotericin B, and they actually, including hypoxia. So it's not commonly on hospital formularies for that reason, to be honest. Ambisome actually has the lowest incidence of infusion-related reactions, and Abelset is comparable to conventional Amphotericin B. And when you compare Ambisome to Abelset, you do see a lower incidence with Ambisome, like in the 19 to 24% without premeds, and Abelset was up to 80% on day 1 without pre-meds. In terms of nephrotoxicity, all 3 of these drugs, as you would expect, are less nephrotoxic than conventional Amphotericin B. And the one study that we have that actually compared Ambisome to Abelset suggested that Ambisome might be the least nephrotoxic of these formulations. Okay, moving on to Flucytosine. This has been available as an oral capsule since 1972. It's our only anti-metabolite with antifungal activity. It inhibits fungal protein synthesis by replacing uracil with 5-fluorouracil, which is one of my chemo drugs, in fungal RNA. It also inhibits thymidylate synthasase via 5-fluorodeoxyuridine monophosphate, which interferes with fungal DNA synthesis. So flucytosine is in vitro active against Cryptococcus neoformans, which is where we predominantly use it. It also has activity against Candida species, except C. krusei and Aspergillosis species. So when we had fewer agents, we used to occasionally throw flucytosine into the mix for managing a refractory candidiasis or aspergillosis. We can't really use it as monotherapy because you see rapid induction of resistance due to mutations in cytosine permease or cytosine deaminase enzymes. Although it could potentially be used as monotherapy for a candiuria. There's not a tremendous amount of data there, but it is considered an option. Primary clinical use is in combination with Amphotericin B for cryptococcosis. In terms of toxicity, this is a drug, because it's a prodrug for 5-fluorouracil, bone marrow suppression, as you might expect, is the most serious side effect. We monitor for neutropenia, thrombocytopenia, which is more common than anemia, usually seen in the first 2 to 4 weeks, and particularly when their flucytosine levels are elevated. So therapeutic drug monitoring does make sense for flucytosine, and doses must be reduced in patients with renal dysfunction. Monitor LFTs, occasional GI intolerances, rare neurological toxicity, and monitor for rash, and we have seen pruritus, urticaria, photosensitivity, toxic epidermal necrolysis has been reported. Okay, moving on to the azole antifungals, which are some of our favorite antifungals in this day and age. I'm going to just kind of hit on fluconazole and its cousin there, voriconazole, as well as itraconazole and posaconazole. And you can see by these structures that there are a lot of similarities between fluke and vori and itra and posa. Okay, so our azole antifungals work by inhibiting ergosterol synthesis via the fungal equivalent of cytochrome P450. That's why we have lots of drug interactions. Okay, so fluconazole, predominantly active against Candida, also has activity against Cryptococcus, decreased activity against Candida glabrata, as we discussed, not active against krusei. Dose-dependent activity, we use 100 to 200 milligrams a day for mucocutaneous infections. For systemic infection, I would use at least 400 milligrams a day. Excellent bioavailability. It's a mild CYP450-3A4 inhibitor. As you increase the dose, you see more 2C9 inhibition as well. And we dose it just for renal function, of course. Itraconazole or Sporanox has been available as an oral capsule form with unfortunately erratic bioavailability since 1992. Then they came up with a hydroxypropyl beta-cyclodextrin solubilizing agent, which allowed them to create an oral solution, which is still on the market, and an IV formulation, which is no longer on the market. And so itraconazole, unlike fluconazole, is hepatically eliminated. There are some things to be aware of when it comes to the PK of itraconazole, particularly when it comes to absorption. So the capsules should be taken with food for maximal absorption, whereas the oral solution with a cyclodextrin solubilizing agent, actually you get better AUC if taken on an empty stomach. Now, so when both formulations, capsules versus oral solution, are taken optimally in healthy volunteers, you see that you get almost twice the exposure to itraconazole with the oral solution in the capsule. So I would not recommend treating anything more significant than fungal nail infection with itraconazole capsules. Also, itraconazole therapeutic drug monitoring is an option. Be aware with itraconazole, if you choose to use it, that it is contraindicated in patients with congestive heart failure. Okay. In healthy volunteers, when they gave IV itraconazole, they saw transient asymptomatic declines in left ventricular ejection fraction, which resolved prior to the next dose. They also seen this in animal models with dogs. In a 10-year span, however, there were 58 reported cases of CHF in patients receiving itraconazole, with 28 hospital admissions and 13 deaths, and no reported cases of CHF with any other azole antifungals. So, something to be aware of. Itraconazole is not always the most pleasant to take. The oral solution can be unpalatable. We can have patients with GI complaints. We have to monitor for hepatotoxicity. Any of the azoles, you have to monitor for rash. There was a warning about perhaps not using IV itraconazole in patients with creatinine clearance less than 30, but currently that's a non-issue because we don't have available product. Let's talk about our more modern extended spectrum azoles, Voriconazole and Posaconazole. So Voriconazole is available as oral or IV formulation in either tablets, 50 milligram and 200 milligram tablets, or a powder for oral suspension. Or IV Voriconazole is available using another cyclodextrin solubilizing agent. Posaconazole or Noxafil is currently only available as an oral solution, 200 milligrams per 5 mL. Currently. FDA approved indications for Voriconazole, invasive aspergillosis, candidemia, and non-neutropenics. Not to say that it couldn't work in neutropenics, but this was how that was an exclusion criteria in the trial. Esophageal candidiasis, and treatment of Pseudosporium apospermum and Fusarium infections in intolerant or refractory patients. Okay, in terms of toxicity, it's important to warn patients about this. Rule of 30, right? About 30% of patients will experience usually minor visual disturbances that usually occurs roughly 30 minutes after they get their drug. Usually lasts for roughly 30 minutes and rarely requires discontinuation. Although they shouldn't drive at night if they notice any change in their vision, they shouldn't drive during the day if they notice visual changes that are problematic. This is usually mild, often associated with IV Voriconazole, and can resolve spontaneously, and the site of action for this appears to be the retina, and via electroretinography they saw that effects normalized within 14 days after discontinuation, so you can tell people this is not a permanent change. Now, separate from visual complaints is encephalopathy, hallucinations, or confusion, and this was seen in the invasive aspergillosis trial, which used relatively high doses in 13 patients versus 5% for Amphotericin B. So this is a real concern. And patients need to be aware that it's possible. We also have to look out for rashes, mostly mild to moderate, but there have been cases of Stevens-Johnson's, TEN, and erythema multiforme. Patients need to know about photosensitivity, which may be more frequent with prolonged therapy, avoid strong direct sunlight, and if a rash develops on Voriconazole, we need to monitor these patients very closely and consider discontinuation if it's severe. We need to monitor LFTs during therapy with Voriconazole due to the potential for hepatotoxicity, and there have been cases of fulminant liver failure, including fatalities here. QTc prolongation can happen with any of the azoles, and there are uncommon reports of anaphylactoid reactions during Voriconazole infusions, although they're far less common than with either conventional or liposomal Amphotericin B. Some important things to know about Voriconazole pharmacokinetics: excellent bioavailability. Actually, Voriconazole should not be taken with food. You shouldn't eat for an hour before and after each dose because a fatty meal will decrease the absorption. The absorption is not affected by pH, so that's not an issue. Excellent distribution, including CNS penetration. Voriconazole is metabolized by cytochrome P450 2C19 for the most part, more so than 2C9 and 3A4. It's important to note there's a genetic polymorphism of 2C19, so people with Asian ancestry have a higher risk for reduced clearance of Voriconazole than Caucasians or African Americans, and the a patient who's homozygous for reduced 2C19 activity would have a 4-fold higher voriconazole level than your average patient. If they're heterozygous, they would have roughly double. And that becomes problematic because it doesn't have a wide therapeutic margin here. Voriconazole has saturable metabolism, kind of like phenytoin, which results in nonlinear pharmacokinetics. So if you increase your dose by 50%, you're not going to increase your level by 50%. You don't increase it by more. Also, it inhibits 2C19, 2C9, and 3A4 itself, creating lots of great drug interactions. Okay, patients with hepatic dysfunction, AST and ALT elevations don't affect the clearance of the drug, although voriconazole could aggravate and make those worse. However, patients with cirrhosis have been shown to have reduced clearance of voriconazole. So the package insert recommends a 50% maintenance dose reduction for Child-Pugh score A or B, and says C has not been studied. Just a quick note that Child-Pugh score has not been validated for patients with acute hepatic dysfunction, i.e. they get chemotherapy and their LFT starts shooting up. So it's a little problematic to use these Child-Pugh scores in those patients. I think there's a good role for therapeutic drug monitoring in those patients as well. Voriconazole with renal insufficiency. So voriconazole clearance is not affected. However, oral may be preferred over IV, at least according to the package insert, if the creatinine clearance is less than 50. And this is because the solubilizing agent is known to accumulate with renal failure and a 4-fold increase in Cmax and area under the curve. And I think on the conversion from PowerPoint, we actually lost part of the slide. My apologies. I just point out that there actually have been at least 3 different retrospective reviews which have gone back and looked at patients who received IV voriconazole with baseline renal insufficiency, and they did not see an increase in renal insufficiency or hepatic insufficiency. The concern was potentially renal insufficiency because in the rats who were given high doses of cyclodextrin, they would accumulate them in vacuoles in their renal tubules. But this does not seem to be, at least thus far, does not seem to be a major clinical issue in human beings receiving IV voriconazole. Okay, drug interactions. This slide has 2 of my least favorite drug interactions, right? Voriconazole plus phenytoin. Voriconazole, you actually have phenytoin inducing the metabolism of voriconazole, so vori levels go down, and you have to increase your voriconazole dose. You may even have to double it if you start at 200 twice a day. The phenytoin metabolism is inhibited by voriconazole, so you're going to have to reduce your phenytoin dose. Lots and lots of drug levels. Rifabutin, you see about rifabutin induces voriconazole metabolism, about a 67% reduction in concentration, 79% reduction in AUC. So you're going to have to increase your voriconazole dose probably by about 50%. But the rifabutin dose will also have to be reduced because voriconazole inhibits rifabutin metabolism. And just forget about rifampin. Okay, it just eats up voriconazole, posaconazole 2, and just spits it out. Okay, voriconazole may be induced by other enzyme inducers, carbamazepine, phenobarbital. We just don't have very good data on this. Definitely therapeutic drug monitoring would be indicated for patients on those drugs. Voriconazole levels may be increased by enzyme inhibitors of 2C19, but there aren't a lot of those. Omeprazole has a modest effect, but is generally not considered clinically significant. Vori also inhibits omeprazole clearance, so you might want to cap your dose at 20 milligrams a day. Lots and lots of drug interactions, mostly via cytochrome P453A4 with immunosuppressants such as sirolimus, cyclosporin, tacrolimus. The second row there are drugs with QT that are 3A4 metabolized and have QTC prolongation, so it would be a double whammy to avoid those. Ergot alkaloids, you get ergotism. Warfarin, actually of interest, voriconazole may be a bigger problem than posaconazole with warfarin because 2C9 may be more important than 3A4 for warfarin metabolism. Potential accumulation of methadone, perhaps more so fentanyl. Many of our cytochrome P450 statins some of our calcium channel blockers, some of our oral hypoglycemics, lots of chemotherapy drugs like vinca alkaloids, busulfan, or other cancer chemotherapy drugs. We talked about phenytoin already, proton pump inhibitors, and a number of our antiretroviral therapy. Okay, for voriconazole, if you're treating a proven or probable invasive fungal infection, it's recommended to load on day 1. Otherwise, you will not achieve the steady state concentration you desire until about day 6. And I just wanted to point out, as I mentioned before, if you increase your voriconazole dose from 200 milligrams twice a day to 300 milligrams twice a day, you actually increase your area under the curve exposure by about 2.3 to 2.5 fold. So that the concentrations go up substantially more than proportionally due to its saturable metabolism. Okay. Therapeutic drug monitoring with voriconazole. I consider this to be very important when you're using voriconazole for the treatment of an invasive fungal infection. Right? Pascual and colleagues had some of the best data here. They looked at 181 Vori levels in 52 patients with invasive fungal infections, and they proposed a therapeutic range for voriconazole troughs of 1 to 5.5 milligrams per liter. What they saw was those patients had, they actually saw approximately a 75% treatment success if the trough was greater than 1 milligram per liter, down to 54% in the 13 patients with subtherapeutic troughs. And they actually also found that they were able to salvage some of their patients with invasive fungal infections who had low voriconazole levels who weren't responding just by increasing their voriconazole dose. And I'm sorry, that slide also had a missing component. In terms of toxicity, I mentioned encephalopathy, hallucinations, and confusion earlier. These authors found that they saw no cases of encephalopathy when the trough level was less than 5.5 milligrams per liter, but 31% with 31% incidence when the trough level was higher than 5.5, and they definitely saw the higher the concentrations, the higher the risk for encephalopathy, up to like 90% incidence if the trough level was 8 milligrams per liter. They did not see a statistically significant increase in cholestasis with higher concentrations, but a suggestion there might be a connection there. Interestingly enough, even though we said omeprazole's inhibition of voriconazole is minor, perhaps for some of our lower metabolizing patients, it may be more clinically significant. They saw it more commonly in our patients with elevated voriconazole levels. So in terms of dosing for voriconazole, if you're treating an invasive fungal infection, 6 milligrams per kilogram PO or IV Q12 times 2, followed by 3 to 4 milligrams per kilogram Q12. The Aspergillosis data used 4. The Candidemia data used 3. Be aware that we have occasionally had patients have CNS side effects during the load. So if it's not a proven or probable invasive fungal infection, you can consider risk versus benefit of aggressive loading. Okay. And we do recommend getting a voriconazole trough level in 5 to 7 days and adjusting our dosing as required to get within the goal range. Persistent neutropenic fever has used the same lower dosing range there. For prophylaxis, mostly studied at the 200 milligrams twice a day, and no food for 1 hour before and after each dose. Switch over to posaconazole or noxaphil. It's approved for prophylaxis of invasive aspergillosis and candidiasis in high-risk patients. So our MDS AML patients undergoing induction, or our allo stem cell transplant patients with graft-versus-host disease and high-dose corticosteroids at a dose of 200 milligrams, which is 5 mLs, 3 times a day with food. Also approved for the treatment of oropharyngeal candidiasis, although it will rarely be used for this, although it is an option in fluconazole or itraconazole refractory oropharyngeal candidiasis to give you an oral option. Okay, it's also been studied for salvage therapy of aspergillosis and zygomycosis, and in these studies they gave 200 milligrams PO 4 times a day, ideally with food, often with enteral supplements. And when patients were clinically stabilized, they would switch them to 400 milligrams twice a day to improve compliance. So, The reason for this kind of dosing is that there's a number of things you need to know about posaconazole absorption, right? So posaconazole, if you give posaconazole to patients and you add an acidifying agent such as ginger ale, which has carbonic acid, you'll see a substantial increase in concentrations, almost twofold increase in this series here. If you give a proton pump inhibitor, which inhibits acid secretion, you'll see a significant decrease in concentration. And if you give both, you still don't quite get back to where you started. Taking the drug with food is critical to achieve therapeutic concentrations, but you can substitute. High-fat meals are give you the best concentrations. However, you can give something like Boost Plus, and achieve concentrations that are similar to that which you would get with a non-fat meal. So it really becomes important to take this drug with food. We know that 200 milligrams 4 times a day gives you significantly higher concentrations than 400 milligrams twice a day, and that's because posaconazole has saturable absorption. Now, in the prophylaxis study in our AML patients, they really didn't see a correlation between concentration and the risk of invasive fungal infection. So we don't generally follow therapeutic drug levels in these patients quite so closely. Also, we know there are much higher concentrations in the lungs with posaconazole than in the serum. And that can be a factor as well. But there is a warning in the package insert, which I would reinforce, is that patients using proton pump inhibitors, that's a major drug interaction with posaconazole, and we do what we can to avoid proton pump inhibitors in patients receiving posaconazole, either prophylactically or certainly therapeutically. Posaconazole is metabolized by glucuronidation, has no major CYP-mediated metabolites. There's a comment in the package insert that there's not enough data to determine if dose reduction is required for hepatic dysfunction. Really, there's very little difference between concentrations in patients with and without hepatic dysfunction. So if I was going to use it in a patient with hepatic dysfunction, I would use full dose. Posaconazole inhibits 3A4 specifically. It doesn't inhibit 2C9 or 2C19, unlike Vori, but like its cousin itraconazole. Excellent distribution, looks to have significant CNS concentrations as well. Has a longer half-life than Voriconazole, about 35 hours on average. This is the only study that I saw that really looked at therapeutic drug monitoring as possibly having a role. And you can see that there they kind of divided patients up, and those patients, this is in salvage therapy of Aspergillosis with posaconazole, and patients with the almost undetectable concentrations, less than 250 nanograms per mil, had the lowest efficacy, and those who had concentrations above 1,000 nanograms per mil seemed to have the best efficacy. But posaconazole therapeutic drug monitoring is probably limited in terms of value, because there's only so many things you can do to maximize your absorption. And with saturable absorption, you can't just keep raising your dose. So 200 milligrams PO 3 times a day with meals for prophylaxis. And you can use a can of Ensure, Ensure Plus, or other similar products. If patient can't take a full meal, consider changing to Voriconazole prophylaxis if your patient really is not eating at all. For invasive fungal infections, 200 milligrams 4 times a day is our aggressive dose. 400 milligrams twice a day is our try to get reasonable compliance dose. Avoid concurrent PPIs. Consider a posaconazole bundle to maximize absorption. So one acidifying agent that you can use as an alternative or in combination with ginger ale or cola would be ascorbic acid, vitamin C, 250 to 500 milligrams with each dose. And ideally, patients to have food or heavy snack, nutritional supplementation, and no dose adjustments for renal or hepatic insufficiency. Just wanted to tell you about a couple of new formulations of posaconazole, which we hope to see in the not-too-distant future, particularly the solid oral tablet, which is designed to release an entire dose of solubilized posaconazole into the small intestine, maximizing oral absorption and being independent of food and gastric pH. So data was presented last year at ICAC, in patients with AML-MDS, and they found that particularly at the dose of 300 milligrams twice a day times 2 doses, and then 300 milligrams daily, that 97% of their patients were able to achieve their goal concentration range. That's substantially better than what we have with the liquid. That hopefully the solid oral tablet will be out next year. The IV is probably going to take a little bit longer, but there's an IV formulation with a cyclodextrin component that hopefully will be available to us in the not too distant future. The dosing will probably be similar, 200 to 300 IV BID times 2, and then 200 or 300 IV daily. Okay, we're almost done. Just to wrap up with the echinocandins, these agents inhibit synthesis of beta-1,3-D-glucan in the fungal cell wall. They're cidal against Candida, but only static against Aspergillus, because Aspergillus only has beta-1,3-D-glucan in the apical tips, the invading tips of the filaments. They have no equivalent component in mammalian cells, which tend to make them pretty well tolerated. This is caspofungin, or Candidiasis, was approved in 2001, approved for esophageal candidiasis, candidemia, disseminated candidiasis, salvage therapy for IPA in patients who are refractory or intolerant to first-line therapy, or persistent neutropenic fever, dosing 70 milligrams on day 1 and then 50 milligrams a day thereafter. You might want to ramp that up to 70 milligrams a day if your patients are on enzyme inducers. Patients who have hepatic impairment, consider a 35 milligram per day maintenance dose in patients with moderate to severe impairment. And there does appear to be a drug interaction with cyclosporin. We see more LFT abnormalities in patients getting cyclosporin in combination with caspofungin. Micafungin, or micamine, is our second FDA-approved echinocandin, approved in 2005. And the micafungin, in terms of drug interactions, has a minor effect on increasing sirolimus levels, although usually that's manageable with therapeutic drug monitoring. You can see an increase in nifedipine, and it's usually manageable with blood pressure monitoring. So those are not contraindications to therapy. You just need to watch those patients. None of the other major drug interactions that we might otherwise worry about. FDA approved for esophageal candidiasis and prophylaxis of Candida infections in stem cell transplant patients, and they used a low dose of 50 milligrams a day for prophylaxis in that study. And we also know that even though it's not FDA approved, actually it is not FDA approved. For a while, it was a little late to the party in terms of getting FDA approval, but it is approved for candidemia and invasive candidiasis, and we know that 100 milligrams of micafungin is equivalent to 150 milligrams a day of micafungin is equivalent to caspofungin for candidemia and invasive candidiasis. So we use 100. And it can be used as salvage therapy for invasive aspergillosis, and we commonly utilize 150 milligrams Q24 when we use micafungin for this purpose. No loading dose is required with micafungin, unlike caspofungin. And last is Araxis, or inidrolfungin. This is our third approved echinocandin, approved in 2006. They're all only available as IV formulations. Initially, the prescribing information recommended reconstituting this with ethanol, but that has since been replaced with sterile water, so that's no longer a concern. Inidrolfungin undergoes slow chemical degradation under physiological conditions, so there's no pharmacokinetic drug interaction issues and no dose changes even for severe hepatic dysfunction. FDA approved for esophageal candidiasis, candidemia, and disseminated candidiasis, and it has been studied in combination with voriconazole for the treatment of invasive aspergillosis, as I mentioned before. Okay, guys, so I really appreciate your time and your attention. If you have any